I thank the chairman and thank the panel for being here today. Ms. Goodwin, I'll start with you. I've met with many groups over the years who have stressed the importance of instituting a nationwide prescription database. As you know or may know, Tennessee borders 8 different states, and the congressional district I represent borders 2. This poses a unique problem because in the absence of a nationwide prescription database, drug abusers in my district will frequently get a prescription for an opioid in Tennessee and then simply cross the border into Alabama or Georgia and attempt to fill another. What steps are you taking to address this problem?
So GAO has not looked into that specifically. When we did some of our review, we did talk to a number of representatives from the HIDA program. So I think actually Mr. Carr can speak more eloquently to that than GAO could.
Okay, thank you.
Thank you, Congressman. I'll try. Well, I know several years ago we were detecting people that were getting prescriptions filled for them or written for them in Kentucky, and they were driving to Miami to fill them. And I don't know how many pharmacies they passed on the way, so I think you can know what they're up to. With the PDMP, that's been implemented, Prescription Drug Monitoring Program, I think that's a good first step. There's some issues with PDMP in that they're all activated at the local, the state level. So in some cases, doctors are required in that state to look at the PDMP to find out if their patient before them has in fact been given a prescription for an opioid or the like by another doctor. In other states, however, it's only recommended, and they don't have to look. So I think we need to do some more work on that. I think, personally speaking, I think a national database makes sense, especially as fluid as our population is today.
And I would agree with you. Thank you. This is for any of the panelists regarding hospice care. Under the current law, to my understanding, hospice care staff are not allowed to dispose of the patient's prescriptions when the patient passes away. This often leads to families sometimes taking narcotics or opioids home with them, or they may end up in their medicine cabinet and be forgot about, or somehow taken out of the home, and it leads to an increase of the drugs being distributed back into the community. What safeguards can we enact to ensure that this problem is dealt with?
Thank you, Congressman. I think it's important for us to be able to have the take-back days as well as enhanced efforts to destroy the medications. Going back to, I think we're getting to a place where opioids, as they are in the market, are going to have companion mechanisms dispensed to patients to be able to destroy the medications. Also, blister pack. We've just enacted laws to limit the initial prescribing in ERs and outpatient. So what happens? We would like to see blister packs for 3 days or 7 days use, and then a parallel system where they can put in a package and destroy it. So I think that technology is needed. I just want to add to nationalizing. I just want to be real careful about that, because we need systems that will connect state PDMPs with other state PDMPs rather than federalizing or nationalizing, because we're able to use our data in ways, creative ways in advance as a laboratory in states that would be a little bit difficult from federalizing the PDMP.
Congressman, I'll just add that FDA, I think Dr. Gupta is absolutely correct. FDA is looking into this blister pack idea, and I think that's very, very promising. To your point, there are 15 billion pills of opioids dispensed every year. Only 6 billion, 40%, are consumed. So 9 billion pills are, as you suggest, going in different places and oftentimes end up in families' medicine cabinets.
If you can answer this for me, I've heard that of the prescription opioid-related deaths, over 90% of those are not the person that the drug was originally prescribed to. Is that your understanding?
I think it's a large number. There are over 11 million Americans who are misusing opioids. So either they didn't have a prescription, or they're not following the prescription.
So, I mean, I think that's a really important point to drive home, is that you know, the physicians are prescribing the opioids. We're doing that at a lower rate, but the opioids are getting in the wrong hands, and there needs to be a focus on punishment for distributing controlled substances, and the patients need to be educated before they leave the office and probably at the pharmacy as well. And if the chairman would indulge, just one last question. I recently met with a group of pharmacists that explained to me how e-prescribing can prevent overprescribing opioids by allowing healthcare providers to see patients' medication history at the point of care, thereby helping them determine if patients are doctor shopping. Have any of you all been paying attention to this movement in states towards electronic prescribing for controlled substances, and if so, have the results been positive?
Congressman, I would say that we have attempted to do that in West Virginia. One of the challenges, I go back to this rural America divide, is that we have places we don't even have broadband in West Virginia. We have places where physicians rely on fax to transmit data. So I think this links to another issue that we really have, which is e-prescribing is only as good as the ability to get to our practices in sometimes very rural parts of the state, and that's a limiting factor. But we do have some type, but it's very hard to be more robust in that.